Professor Seyhan Özkan was born in London, obtained her bachelor degree in medicine and surgery in 1986. She did her residency training in ophthalmology in 1990. Professor Özkan had finished a fellowship training in pediatric ophthalmology and strabismus from 1991 to 1992 from Moorfields Eye Hospital with late Mr. Lee. Professor Özkan was the ex-president of the European Association of Strabismus and the International Strabismological Association. She has more than 100 published papers, and she authored more than 6 book chapters. So today, in collaboration with our business partner, our great company, Novartis Jordan, we are very happy to have Professor Seyhan Özkan to talk to us about lost muscle in strabismus surgery, a dangerous complication that can happen with every surgeon. She will give us useful tips in the surgical management. Dr. Seyhan, you have the mic.
So, thank you so much. And good evening, and Mr. Moderator and dear colleagues. First
Dr.
of all,
Seyhan, can you show your camera, please?
Yes.
Dr. Seyhan, camera is shown.
Okay.
We can see her.
Okay. So I think you can see. Okay, no problem. So first of all, it's my distinct pleasure and honor to join for this web conference, and I'd like to thank Dr. Raed Shatnavi and also Jordan Ophthalmological Association for this kind invitation for this web lecture. And I'd also like to thank the President of International Strabismological Association, Dr. Rosario Gomez de Liano, for kindly letting this event be held in collaboration with ISA. And also thanks goes to the Novartis company. Without them, we would not be able to have this meeting. So now I think I'm going to share my slides. I think now, is it okay now? Can you see my slides?
Yes, doctor.
Okay, thank you so much. So my topic today is the lost muscle problem in strabismus. And before starting, I'd like to say a couple of words about the International Strabismological Association. And ISA is one of the oldest subspecialty societies in ophthalmology, and it's purely dedicated to strabismus. And since 1966, ISA organizes regular meetings in strabismus. And among the membership benefits, there is to receive the free meeting transactions, as well as there is also enjoying the discussions in Strabismus Forum in the society website. And so those who have special interest in strabismology are all welcome to join ISA. So now let's move to our topic today. I have no potential conflict of interest to disclose. So during this talk, I will speak about the etiology and types of lost muscle, preventive measures, clinical presentation, and then after treatment of this difficult problem. So lost muscle is a challenging problem of strabismology, and it is also one of the most serious complications of strabismus surgery. But lost muscle may develop most commonly in strabismus surgery, but it may also develop in pterygium surgery or retinal detachment surgery, as well as orbital surgery. And especially in recent years, endoscopic sinus surgery is another source of lost muscle. And lost muscle may also develop after trauma. So when we speak about lost muscle, first of all, we need to decide how to call this problem. Is it the muscle what is lost, or is it the surgeon who is lost? If the problem is the lost surgeon, this is the very harmful and very dangerous position, because the surgeon has to be aware of all the anatomical aspects, and the surgeon mustn't be lost in the eye, in the orbit. So now let's start with the etiology and types. So in lost muscle, there are some subtypes. So the muscle may slip in its capsule, and in that case, the sutures do not include the muscle, the fibers itself, There's the empty capsule, and the recognition of this problem is in the postoperative period. So when the muscle is lost after cutting the muscle, so there are two options. The first of all, this problem may develop when you make your recession, and in that case you have a long muscle including the tendon. However, it may sometimes occur after you resect the muscle, and in that case this is a worse problem because you have no tendon, the muscle is shorter and it retracts more in the posterior orbit. And the extraocular muscles may also break. So this break usually develops at the tendon-muscle junction area. And in the Anglo-Saxon literature, this problem is called as pulled-in-two syndrome. And it most commonly occurs in medial rectus and followed by inferior rectus muscle. So inadvertent transection is another cause of lost muscle, and this problem develops during oblique muscle surgery. So inferior rectus or lateral rectus transection may develop during inferior oblique surgery, and superior rectus transection may occur in superior oblique surgery. And the etiology is blind hooking. So at all steps of this oblique muscle surgery, we need to be under direct view. So when we look at the etiology of lost muscle when we perform a strabismus surgery, the first factor for the etiology is unfortunately poor surgical technique. And also this is followed by inexperienced assistance. And also poor instrumentation is another factor. And we may have problems with the suture quality. Well, I must say that most of us use the 6-0 vicryl sutures as a golden standard. This is a good suture, but it's not perfect. Sometimes we may have problems with the suture. But sometimes the patient may have some individual risks. And what are these factors? Well, these are, first of all, old age and previous surgery, paralytic and restrictive problems, CPEO, Ehlers-Danlos syndrome, and trauma are the basic risk factors to have a lost muscle during surgery. So I would like to say some simple preventive measures. Well, actually, these preventive measures are something so simple. These are all actually the basic rules of strabismus surgery, but we need to remind this. First of all, full thickness locking bite at the edge of the extraocular muscle, careful removal of the anterior Tenon's capsule, not to handle the sutures with serrated instruments, and to avoid unnecessary posterior dissection. And I would like to say more about this unnecessary posterior dissection. Previously, Osama Hakim, in a very nice study, he demonstrated that under topical anesthesia, during strabismus surgery, when he cut the muscles, he saw that despite the muscle was disinserted, the eye can do a pretty nice movement. And this movement is, in some of the patients, is so nearly full movements. But we must emphasize that these movements are observed just at the time of disinsertion. So when you leave a muscle in that position for a long time, so the effect of the antagonist starts. But this is the immediate disinsertion time. But many muscles may have pretty good function, which shows that the soft tissue structures play an important role. So the second statement in the slide is not belong to me, it belongs to Joe Deemer, who demonstrated the very detailed anatomy, and he discovered and he showed us the pulley system and so on. So what he says is perimuscular connective tissues deserve surgical respect and should not be needlessly dissected. Of course, we have to make dissection for strabismus surgery, but we need to do this just as required, no more than that. So if we go to the clinical findings in lost muscle, first of all, it's large over or under correction, marked on incompetence and limitation of ductions in the field of action of lost muscle, marked nystagmus and widening of the palpebral fissure. So what can we do to examine when we have suspicion for lost muscle? Well, the first thing you can do is saccadic velocity measurement. I said this first thing, but this is mostly not available in clinics. But if you can do it, it gives you a good idea. And the second one, force generation test. It's a very useful test, very simple to do. You can do in the office setting just with using a cotton tip applicator. And it gives you an idea whether there is some force in the field of action of the muscle. I sometimes hear my own voice as an echo. So if it is possible to remove this voice, I'll be happy. So now let's move towards the other method, which is ultrasonography, or especially UBM. It is very useful to demonstrate the insertion site, and UBM is very precise to show the insertion size. As well as in recent years, anterior segment OCT is demonstrated to be very precise to show the insertion site. And UBM also may give some idea about whether it is a muscle or scar tissue, but this is just an idea. But the problem is it doesn't, both of these methods do not show the very posterior part of the globe. MRI, on the other hand, demonstrates the localization, the morphology. It's not so precise in insertion site, but it may also shows us the function of the muscle if you do a kinematic MRI examination. So this is important. Why it is important? Because if there is any nerve damage in the muscle, then relocation of and all the efforts for relocation will be a useless effort. So if we go through the management of the problem, so let's start with the slipped muscle problem. Well, in all slipped or lost muscle, and try not to pull the eye in the opposite direction. But as you can see in this photo, we pull this eye quite a lot because we need to reach to the muscle, but try not to do it so much. And in that case, you need to search for the muscle through the empty capsule. As you can see in this photo, in this figure here, you need to go through this empty capsule, and then this will take you towards the muscle fibers. So in previous studies, which is one of them is from my colleague from Turkey, Dr. Duranoğlu, when a slipped medial rectus muscle is advanced, the effect is in between 2.6 to 4.2 prism diopters per millimeters. But these are very rough numbers. So if there are any straight scars, you need to excise those scars. But the important thing is slipped or lost muscles lose their sarcomeres, they shorten and they become stiff. So they all become restricted. So in tight extraocular muscles, the effect of advancement could be much more than you expect for this. So the amount of advancement and resection is totally an intraoperative decision. So when we talk about stretch scars, I need to say a couple of words about stretch scars because this can be confused with the slipped muscle problem. So stretched scars is responsible nearly 50% of the late onset consecutive strabismus, and these were nicely demonstrated with Iron Ludwig's study. And the onset in stretched scars is gradual, and it is after 4 months, and it can be even later than that. But however, in slipped muscle, the onset is earlier. In stretched scars, there's a limitation of ductions, but sometimes there may even be no limitation. And if there's any limitation, this limitation is not so much. But in slipped muscle, we expect a larger limitation of ductions. And the segment in stretched scar is shorter compared to the empty muscle capsule in slipped muscle, it is longer. And the stretched muscle scar is a thick, lac amorphous tissue. And the slipped muscle has a longer empty capsule, and it's clear. You can see the hook underneath easily. And the recurrence rate is high in stretched scars. So when you operate a stretched scar, it is recommended to use non-absorbable sutures. However, in slipped muscles, this is up to you, and some are on the side of using non-absorbable, some of them are on the side of using absorbable sutures. So we have some preoperative evaluation problems, as I mentioned, in stretch scars and slip muscles. So in a nice study, the authors looked for naming those conditions, and the strabismus experts looked independently, evaluated the muscles as in reoperations, they evaluated the muscles as normal, stretch, scar, slipped, or lost muscles. However, inter-examiner agreement was just 58%, which was quite low actually, and this disagreement was highest in stretch, scar, and slip muscle problem. So the authors proposed the term to use abnormal scleral attachments to identify these problems, as there is no such agreement. However, we know that stretch scars and slip muscles may coexist. So, is it a good idea to name all of them abnormal structures? Well, now let's, in this slide, you see on the left side, the treasure of Petra of Jordan, where our moderator lives, Dr. Shatnavi. And on the right-hand side, you see the Celsius Library of Ephesus of Turkey, which is located in the city where I live, Aydın. And when you look at these two magnificent archaeological buildings, at the first glance, they may look similar, but actually they are so different than each other when you compare them. So I think stretch scars and slip muscles are as different as treasure of Petra and Celsius Library of Ephesus. So we need to identify them. Now I would like to demonstrate some case examples. Well, this lady was, when she applied, we found that she had a right consecutive exodeviation with significant limitation of adduction. And this problem occurred a little bit late after surgery. So I didn't want to have any MRI for this patient. And during the operation, so please take care to the forced adduction test. On adduction, you can see there was a contraction, but on abduction, you can see it is totally free. On abduction, there is no resistance, the resistance that you would expect. So here you can see that, you can see the muscle hook very clearly. However, on this side, the tissue is thicker in an amorphous shaped tissue, and there is no muscle tissue inside. So there is both slip muscle as well as a stretch scar in this patient. So this stretch scar and the empty capsule was removed, and the muscle was advanced, and it was closed with a +1 positive forced adduction test, and the lateral rectus muscle was recessed on adjustables. So now let's see what happened. After adjustment, I left her with a very small esotropia. I reduced the lateral rectus recession, and she was okay. But on postoperative second week, this contracted medial rectus muscle contracted even more, and she had this esodeviation. Well, as she had a stretch scar problem, I used non-absorbable sutures in this patient. And despite I am using adjustable sutures in all adult surgery, and as this patient has a stretch scar and slip muscle problem, I wanted to put it on stay sutures, but it could be a wrong idea. Okay, so we saw that she had an esоdeviation, but at this stage, what can we do? Because after adjustments, she was pretty good. What I need to do at this stage is to stop the contracture of the medial rectus muscle, which I can do with a toxin injection at this early postoperative period. And then after 1 week, she became a little bit of exotropia, and she had some limitation of adduction. And I don't have her last photos, but she's going to be fine. So the botulinum toxin may balance the contractile force in the early postoperative period if you face with a restriction more than you expected during surgery. So when the muscle is totally lost, on management, there's no question that early intervention has a higher success rate. So there's no question on that. However, sometimes the patients may come to your clinic at a later stage with excessive inflammatory reaction. And in that case, it is better to wait for 6 weeks till this inflammation resolves. But what happens during this time? It was demonstrated that the unopposed contracture in a lost muscle may occur as early as 2 weeks' time when you leave it alone. And on the other hand, if there will be any attachments in the soft tissues or in the remaining muscle fibers, these attachments will attach the globe in a posterior location. So we need to stop these. So how can we stop this? Then botulinum toxin at this stage is very helpful and very effective to prevent the contracture of the antagonist and posterior attachments. Now, in this figure, I would like to say it once more. When a muscle is lost, and this is the unopposed contraction here, so the eye moves towards the antagonist's direction. So if there will be some attachments, these attachments will be at point B, which is a very posterior point. But if you inject toxin and keep this eye in this primary position, then you will prevent this contracture, and on the other side, you will have these attachments will be attached to the globe at point A, which is a much more anterior location compared to point B. So this may enable you to find the muscle more easily in a secondary exploration. So during the surgery, if the muscle is gone, so this is a period where adrenaline rises immediately. So the first thing to do is don't panic, be calm, and inform your anesthesiologist about the problem that you have. So the patient must have a good anesthesia, but you must warn the anesthesiologist that you need to have the ocular cardiac reflex. And if you're not using it already, try to use magnification. And the very important thing to do not make more harm. Well, this figure in the right-hand side is used in my country as a symbol of traffic monster to stop the drivers not to be a traffic monster. But when you have such a problem, you shouldn't be a monster surgeon. You shouldn't fall into panic. So take a deep breath and consider you were there, and then go on your work. So what should you do in order to find the muscle again? The first thing to do is don't pull the eye. So if you pull the eye in the other direction, the muscle retracts posterior to the Tenon's capsule penetration site, as you can see in this figure. And retropulsing the globe may help you to catch the muscle again. And the very common mistake, especially among young colleagues. So search the muscle in the correct plane. So when the muscle is inserted on the globe, the search will be on the globe. But when it is lost, when it is disinserted, when you search through the globe, you will find yourself in the optic nerve. So you need to search for the muscle in the orbital side, and you need to go this side, and oculocardiac reflex also may be very helpful. So one of the major things is avoid blind fishing. You have to see everything. So blind fishing is totally forbidden, because in that case, you may face with an adherence syndrome as a plus nightmare as a plus problem, and use all the facial clues of surrounding facial structures, and in superior rectus, lateral rectus, and inferior rectus muscle. And finding the obliques first may be helpful because their intramuscular septa may hold those muscles. And it was reported by Shokida that trypan blue may be helpful to identify tissues, and she demonstrated that it stains fibrotic tissue, muscle sheath, and tendon, but not the muscle fibers. Well, I don't have experience to use trypan blue in strabismus operations, but it is good to know that trypan is available in all operating theaters, and if you need, you can at least try whether it works or not. So I must say a couple of words about the medial rectus muscle, and I call this as the unfriendly medial rectus muscle. Why I call it is like that? Because it is the most commonly lost muscle. Maybe it could be because that medial rectus muscle is also the most commonly operated muscle in strabismus surgery, but it is the most commonly lost one. However, it has no facial attachments with the oblique muscles, and it recoils easily posterior to the penetrance of Tenon's capsule. Well, I must say that what we mean by recoil, it's not like a spring that goes back, and it recoils posterior to the Tenon's capsule, but within the orbit, and because of the fibrous septa within the orbit, the muscle remains there. So this patient was referred to us after lost medial rectus muscle during pterygium surgery. And this patient had no strabismus problems before the operation. And now he had diplopia, a very large exotropia, and all signs of lost muscle you can see here. There were limitation of adduction is very severe, and you can also see the increase of the palpebral fissure there and the slight exophthalmos. So this was the next day after first surgery. So he underwent an MRI, and we saw the muscle there. It was not too far, but it was posterior to the equator area. And on the other hand, when you look at the coronal slice, you can see the gap between the muscle and the globe, so the muscle was not attached to the globe. So these photos are from surgery. As you see here, we don't pull the eye. We go towards the orbital side, and the muscle was easily captured. It was sutured and reinserted. This is the post-op second day. And after relocation of the muscle 1 month later, you can see that he has no squint, no diplopia, and the adductions are very well. So in that kind of muscles, the results are quite satisfactory. Now, this gentleman was referred to us after lost medial rectus muscle during strabismus surgery. Well, this gentleman has a left sensory exodeviation. The lateral rectus muscle is recessed, medial is resected and then lost. And he also had an infantile cataract, as maybe you can see here. So he had a large exodeviation and a significant limitation of adduction here. So in surgery, you see that the first surgeon put some sutures in the Tenon's capsule and the insertion area, which is a good thing to do because it may enable easier access to the muscle. And sometimes suturing these soft tissues may also help for some adductions. As you can see here, we went through the Tenon's capsule, and then the muscle is right there here. We don't pull the eye to the other direction, and it looks as a strong tissue. I think this is the medial rectus muscle, but during lost muscle surgery, you need to be very slow and very patient because quick attempts may cause damage to the muscle. And this is the postoperative fourth day after the first operation. So you need to secure everything and don't hesitate for putting more sutures, suture all the tissues that you consider that may be helpful for you. So the muscle is dissected, and I see that this is a quite lax muscle, so I decide to make a small resection for this muscle. So then afterwards I put an additional suture there. And the amount of resection is totally, this is up to the muscle elongation test, and you can see the muscle is there. So then the muscle is sutured with absorbable sutures. Now, 1 week after the second surgery, okay, the ductions is quite good, but this patient still had this exodeviation. So he had already 2 operations. So at this stage, I prefer to make a toxin injection into the left lateral rectus muscle. And this is 1 week after toxin injection, he became a slightly esotropic, and this is 2 months after toxin injection. And despite he had a blind eye, he did very well in long term. So this is another patient that I like to demonstrate this patient to my residents a lot, because this patient is a very, I think, a good example to demonstrate us how a straightforward strabismus patient may become the most complicated strabismus patient. So this lady originally had an esodeviation. So she had strabismus surgery, the medial rectus is recessed, lateral rectus was resected, and then the lateral rectus muscle was lost. And when she was referred, it was post-op 7th day. And as you can see here, she had some ptosis and she had some traumatic surgery, it is obvious. And on the other hand, when we look at with slit lamp, and all under the conjunctiva, there was orbital fat tissue. So this patient also was having an adherence syndrome. And she also had a significant limitation of abduction. So at this stage, I didn't want to operate this patient at this stage. So I wanted to wait for this inflammatory reaction to resolve. But we know that during this time, there will be contraction, and during this time, there will be lots of adhesions because she also had an adherence syndrome. So what can we do? While waiting, we are willing to keep the eye in primary position. So this was what we did. And so toxin was injected into the medial rectus muscle in the left eye. So you can see the toxin-induced limitation of adduction, lost muscle-induced limitation of abduction, but the eye is orthophoric. So during this waiting time, we kept the eye in primary position. So this ptosis is not because of toxin. This was after her surgery or after her strabismus surgery. So now 6 weeks later. So please have a look at the forced action test. It was positive both on adduction. This lateral rectus is lost, but it is positive on adduction as well as abduction. So there is the leash and reverse leash effects there. And so you can see the repeat forced action tests there. And in this eye, and scar tissue was also found around the medial rectus area, and this scar tissue was excised. I think it was because as there was orbital fat tissue underneath the whole conjunctiva. And despite we waited for 6 weeks, you can see that there are lots of hemorrhage and lots of adhesions. You must be slow in these operations, and you need to use all the attachments. So we saw an attachment. So we are going to make a very slow dissection. And as we do the dissection, as you can see here, there was unfortunately nothing. So it was just the conjunctiva adhered to the insertion site. So now you can see how far we are back compared to the cornea. You can understand how far we are. So this is the muscle. We can hold the muscle there, but it's very tight, and there are lots of adhesions, and we know that orbital fat tissue is in the area. The posterior Tenon's capsule was destroyed, and you can see the fat tissue here. These are, I think you can clearly see, I hope. And this is the muscle. We cannot pull the muscle there. So we need to dissect this slowly and carefully. So we can pull this muscle with a little bit of recession. And then it is also important, luckily, as we waited for some time, the orbital fat tissue did not come forward. I still try to dissect the fat tissue area in order to, with an attempt to free the muscle more. So we have been successful a little bit to free the muscle. So the muscle is sutured, and we put long-acting steroids, and then the conjunctiva is closed. So you can also see the orbital fat tissue there. So this is 2 months after the second surgery. So when you have an adherence syndrome, as I mentioned, there are leash and reverse leash effects, and you cannot have a free movement. But this patient has limitation of both adduction and abduction. And you can see that she is orthophoric in primary position. And this is the optimal result that can be obtained in such a patient. And the patient was also satisfied. So this is a small memory from a previous ISA meeting that was held in Istanbul. It was in 2010, 10 years ago. Now let's skip to traumatic lost muscle problem. Well, this boy had a post-traumatic lost inferior rectus muscle, and this lost inferior rectus muscle was actually ruptured, and it was immediately repaired. But despite this immediate repair, you can see that he ended up with inferior rectus palsy. You see the underaction of the inferior rectus muscle with a large hypertrophy. So if we go back to the operation photos, and this muscle was successfully repaired by my young colleague on call, and he was able to, Dr. Chakmak was able to find the posterior fibers of inferior rectus, and he successfully repaired this. And 3 days after this repair, the patient underwent an MRI, and we can see that it looks pretty good. However, 6 months later, denervation atrophy developed in this inferior rectus muscle. So we ended up with inferior rectus palsy, and he underwent inverse NAP operation with left inferior oblique anterior position, and this is his postoperative appearance. And despite he is doing quite good in down gaze and primary position, he had some limitation of elevation on abduction. But till now, he is doing quite good and stable. So this is another patient that I could never forget. Well, this patient was injured with a ram horn, and he had a superior oblique laceration as well as superior rectus laceration. So he had severe eyelid trauma, and my colleague on call, Dr. Kerr, he called me into the theater that they told me that there were some extraocular muscle-like tissue around the surgical field, and you can see that this is the eyelid. So the access was so easy because everything was open. But what we could see here, you see this is the superior rectus muscle here. It was possible to reach the posterior fibers. It was just gone in from the posterior side. But have a look at here. This is the superior oblique tendon, and this is the superior oblique muscle bulk itself. So this is the unique time that I have seen the supraoblique muscle bulk itself, because it's on the actually in the retrotrochlear area, but this was gone. It was not possible to repair. So now what happened the next day? So we lost superior rectus, we lost the supraoblique, and there's a large hypotropia. Unfortunately, there was also limitation of abduction. So at this stage, what can we do? Obviously, there was also a component of adherence in this patient. So what I could suggest is just to keep this eye in primary position and to inject botulinum toxin into the right inferior rectus muscle. So after toxin injection, the eye elevated, the eye elevation is of course limited. The overaction of inferior rectus muscle significantly decreased, and on the other hand, luckily, abduction, there is no longer limitation of abduction. So this gives us the option to perform a transposition surgery afterwards. And 6 weeks later, he underwent a vessel sparing transposition. The vessels could only be spared in the medial rectus muscle. It wasn't possible to find a ciliary vessel in the lateral rectus muscle. And this is his postoperative appearance. And despite this huge problem, he had a pretty good elevation. And surprisingly, he did not have any torsional diplopia problem. And so this could be because that this strange injury that made a circle in his orbit, and probably the nerve of inferior oblique was also destroyed during this trauma. So now I would like to say a couple of words about the previous literature. It's not going to cover all, but I just want to give you some idea with some previous series. When we talk about lost muscle, we see that the medial rectus involvement rate is quite high. And when we look at the relocation rate of medial rectus muscle, it can be as low as 10% or it may be higher, but in Park series, it is just as 10%. Then when we look at the slipped muscles, again, medial rectus involvement is very high, but now the relocation rate is quite high. And it is, we can say that nearly 100% of those cases, it is possible to find the muscle. So there are also some alternative methods to find the lost muscle other than the subconjunctival approach. But in all of these reports, it is mentioned that if standard conjunctival approach fails, and these methods are transcutaneous medial orbitotomy, transnasal endoscopic approach, transcaruncular incision, and anterior orbitotomy. But these methods should be evaluated with potential risk of complications, and you need to be sure about the nerve supply, because otherwise it will be a useless effort. Well, I have no personal experience with those methods, but if I'm doing a secondary surgery in a lost muscle problem, and if in this second surgery, if I cannot find the muscle, instead of referring to an orbital surgeon, I prefer to go on with what I have with transposition surgery or toxin or so on. But these methods are in the literature. There are very nice results with those methods. So in this schematic representation, I tried to demonstrate what is done in those methods. So in these orbitotomy approaches, you find the muscle from the orbital site outside the muscle cone, and then after the muscle is found, you need to take the muscle into the subtenos area from here, and then you need to sutures. But of course, for these procedures, the nerve supply must be intact. So if all attempts fail, then transposition surgery could be considered. And the potential problem with transposition surgery is you may not be considered to do it at the first stage when you lose a muscle, because you may lose a muscle when you already operate you've already operated 2 rectus muscles and lost 2 ciliary vessels. And if you do with any type of transposition surgery at this stage, will be a risk for anterior segment circulation. So at this stage, you may consider using toxin into the antagonist muscle, and you may consider vessel sparing technique or Nishida type transposition without disinserting the muscles. And for the inferior rectus muscle, don't forget that you have the advantage of inferior oblique muscle, and inferior oblique anterior position may be quite helpful. So lost and found muscles may function even years after surgery. So if you see a patient who had an operation 30 years ago, if you can find the muscle and if there's a good innervation, this muscle functions. And lost and found muscles may have contracture and may not be sutured to the original insertion area. And you need to make sure that the muscle receives innervation, especially in traumatic cases. So the take-home messages. Well, I think this statement is did not even fit well because you're all at home. We are all at home. So maybe I must say message to remember or message to put into the pocket. Okay, these are first. Do not forget the basic anatomy and rules of surgery. Do not be the lost surgeon and be familiar with the anatomy very well, especially with the soft tissue anatomy. And do not make blind fishing. An adherence syndrome is much worse than a pure lost muscle problem. And use the appropriate examination methods. Botulinum toxin A has a significant role in management of lost muscle, especially to prevent the contracture of the antagonist as well as managing the residual deviations. An acceptable outcome is usually possible either with retrieval or transposition. So I would like to add an announcement at the end. The next ESA-ISA joint meeting, which was planned to be held in September, Paris 2020, is postponed to April 21st to 24th, 2021 because of the COVID-19 pandemic. And the standalone ISA meeting is going to be held in Cancun, Mexico in 2022 as planned before. And I would like to thank you for your attention. And I hope you did not sleep while I was talking so much about the lost muscle. So if you have any questions, I will be glad to answer if I can. Thank you so much.
Okay. Thank you. So, Dr. Professor Özkan, I hear my echo actually. Anyway, so Professor Özkan, thank you very much for this very interesting lecture about helpful tips, the surgical management of lost muscle. Actually, we have several questions from the attendees. One was from Dr. Professor Mu'taz Gharaibeh. Dr. Mu'taz, can you ask your question? You can unmute yourself and ask the question if you want.
Well, thank you, Dr. Dr. Özkan, thank you very much. تشكر إدرم. It's always our pleasure to have you with us and to hear your talks. They are really informative every time. And thanks for ISA, thank you for Novartis, and special thanks for Dr. Wright for putting all these together. It's really amazing. My question is regarding the botulinum toxin, and it's divided into, do you use Botox or Dysport, or you do not have any difference? What's your dose, if you are going to use that? And will you do it under local? Will you do it in the OR, or you would just do it in the clinic?
Thank you, Dr. Gharaibeh. It's nice to hear your voice, actually. And so I must say that I routinely use Botox, but for a period of time, I also used Dysport when our hospital was able to buy Dysport. For the doses, for Botox in adults and in children, I use 5 units of toxin for the dose. I use a fixed dose. I only increase the dose if there is a thyroid ophthalmopathy, and I only reduce the dose if I'm injecting an infant. And for Dysport, as you know, when you inject eyelids, the difference is when you try to convert this port to Botox, it is 1 to 4 and so on. But for the extraocular muscles, it's not like that. For this port, you don't need to change the units. So for when I use the Dysport, I also use 5 units. It doesn't, and I didn't see any clinical difference. And I must say that my mentor, John Lee, who taught me how to use this agent, and his routine dose for Dysport was 2.5. But I was using 5 units, but there's no need to change the dose for the extraocular muscles, not for eyelids, but for the extraocular muscles. And I think you also asked how I inject the muscles. For all adults, I do it in the office setting, just with topical anesthesia in the office and with the EMG control. And with I have the small instrument that has just the voice control, a simple EMG, but you can also use a complicated EMG if your neurologists allow you to use. And so the patient receives the injection and then goes afterwards. Just for children, it has to be done under ketamine anesthesia. And for children, I also use the EMG, but just for infants, I inject toxin without using EMG with the help of Mendoza forceps.
Okay, thank you, Dr. Seyhan. We have a question also from Dr. Fatma Akbar. Do you want to ask your question? Do you want to unmute yourself, Dr. Fatma Akbar, and ask the question?
Yes, hello, good evening. Thank you very much for your talk. It was very nice and very clear. I just like, please, to know, how can I know that the muscle innervation is still functioning if I have a traumatic lost muscle and I plan to reattach the muscle again? Thank you.
Thank you. This is a very good question. I think especially in those traumatic ones, asking for an MRI is my routine, and I want to see the patient. But I want to see the muscle. First of all, is it possible to reach this muscle? What is the level of the rupture or where the muscle lies? But on the other hand, at the first stage, just the size of the muscle will not give you information about the innervational pattern of the muscle. So in that case, you need to make a kinematic MRI, which means you need to make this examination on gaze positions. This is a difficult examination, but you can do it simply. Our radiologist friends shortened the time of kinematic MRI. Normally, kinematic MRI is done with 7 gaze positions, but just 3 gaze positions will give you enough information. Let's say if you're dealing with the medial and if you're looking for medial or lateral rectus muscle, in the axial plane, if you have just one midline orbital scan on left gaze, on primary and on right gaze, it will give you enough information whether the muscle demonstrates any contraction. Or if you are looking for the vertical rectus muscles, then you need to have a sagittal scan. Up gaze, primary and down gaze will give you sufficient information. And for adult cases, it is not very difficult to do. And of course, as I mentioned, first generation test can give you very simple information if you need to have some information. But the trouble with this fourth generation test is, as it was demonstrated that when the muscles are totally disinserted, there may still be some function towards the disinserted muscle. So fourth generation test doesn't show you if you feel some function, Is it disinserted, or is there any innervation or not? It doesn't give a very clear idea, but you can feel whether there is some force pulling the eye.
Right, thank you for your answer. We have also a question from Dr. Ibrahim. Dr. Ibrahim, can you unmute yourself and ask the question about the antagonist chemodenervation?
Yes, thank you. You said about the botulinum toxin injection in the antagonist, and I think it is a great idea to do that to prevent the contracture. But don't you think that will affect the calculations for the transposition surgery afterward? Or do you have fixed measures for the transposition surgeries? Thank you.
Well, of course, transposition surgery is our last choice. But if we will consider to go on with the transposition surgery, I mean, if you cannot find anything with the muscle, and if you're considering a transposition, and consider as if you're treating a 6-nerve palsy, a total 6-nerve palsy. What you do a transposition, and you also weaken the antagonist medial rectus muscle. So it is very similar. So making a toxin injection into the antagonist will not bring you much trouble. At most, you may have some period of overcorrection, which is actually not bad, and which is something that you wish to do. So I don't think it's going to be a problem.
Okay, thank you. And we have a question also from our colleague. He's a glaucoma surgeon, Dr. Mohannad Lebdour. Can you ask your question, unmute yourself and ask the question, please? So Dr. Mohannad has a question about management of diplopia after glaucoma drainage devices, the Ahmed valve, or any valves. Dr. Mohannad, do you want to ask the question? Okay, so he has a question. What is your preferred way of management of diplopia after glaucoma drainage devices? Is it Botox injection? Is it removal of the device, surgery, prism glasses?
Well, this is totally dependent on the degree of the problem. If there is, if there is very small deviation and in an elderly patient and so on, you can just use a small prism and so on. But if the problem is more significant, what I do in glaucoma implant surgery is very similar what I do in retinal detachment surgery for scleral buckle problems as well. So my first choice in those patients, if I cannot fix the problem with prisms, or if the deviation is large and so on, my first choice is to use botulinum toxin. And because, when you go on with surgery, and usually the source of the problem is your, let's say, Ahmed glaucoma valve, or in retinal detachment surgery, the buckle and so on. But removing these devices brings the patient new problems. So my first choice is botulinum toxin before considering any surgery. Or on the other hand, of course, there's a variety of options, but I think as you ask as a glaucoma surgeon, I consider that you mainly ask about the Ahmed glaucoma valve. And the basic problem that develops in this type of surgery is limitation of elevation. So in that case, instead of, if I'm not going to stop the problem by injecting toxin and so on, if I would go on surgery, I would first consider to do a surgery in the sound eye to stop the elevation. But of course, it is the patients may present in a large variety, and it is totally dependent on the problem that you had, whether the patient had any torsion and so on. So this is large, but toxin has a significant role in this group.
All right, thank you. We have two colleagues raising their hands. Dr. Khalil As-Salim. Can you ask your question, Dr. Khalil?
so much for a great talk, Dr. Seyhan. I have one case where there is congenital absence of the muscle, the medial, the lateral rectus, and when we did MRI, we could see just a small slender muscle of the superior or the inferior rectus. The patient didn't have any previous surgeries, and the condition is bilateral. The patient has a very large angle exotropia. I thought of doing a Prolene stitch or like a 4O Prolene and attach the insertion of the muscle with the medial wall. Do you have any experience regarding treating such cases? I know it's like 1 in a million, but I really need some guidance just before embarking on such a patient.
Well, if I understood correctly, you are asking about a patient who had bilateral aplasia of 4 rectus muscles?
Of the medial,
yes,
medial and lateral.
Yes, aplasia of 4 rectus. Yes.
Rectus of 4 rectus muscles, and it is bilateral.
Yes.
If there is any trace,
yes.
It may be a subtype of congenital fibrosis problem, because in those cases, the muscles may also appear in a very thin band shape. So in any case, if you face with a large deviation, you need to create a pulling force, and these patients usually they have a very significant orbital fibrosis element. So it depends on during surgery what you can find. Despite you didn't see anything on MRI, sometimes you can see some remnant bands and so on, which may be very useful for you to fixate the eye in primary position. Of course, fixing the eye to the periosteum, to the medial periosteum could be a choice, but you must have a pulling force in the lateral rectus area. So I think you need to have a look to the medial and lateral sides, and sometimes these patients may have some additional accessory bands and so on. So the forced action test may give you a lot of idea during surgery.
Yes.
Okay, thank you.
Thank you. Thank you so much.
Yes. Go ahead, Dr. Khalid. Do you want anything else?
I was wondering if there are any other ideas other than what I thought of. I really tried to review a lot of articles, to check on the ways of treating those patients. Some they proposed putting a silicone band, as you mentioned. I was wondering if Prolene, 1 or 2 Prolene stitches might do the job or not. Do you have any other thoughts?
Very helpful. And you may also consider to look for the oblique muscles, but I must say that your surgical plan may totally change depending on the surgical findings, because you may find very unexpected thin bands in this group of patients, those who had congenital malformations in development of especially the nerves and the muscles.
Thank you.
All right, thank you. Thank you. We have another question from Dr. Manal raising her hand. Dr. Manal, can you unmute yourself and ask the question if you want?
Yes, thank you. Thanks for this nice talk. I just need to know, do you consider at any stage working on the other eye? And in that case, how is the hearing slough will be applied? Thank you.
So I couldn't hear the last part.
So do you consider working on the other eye in a lost muscle? If you have lost muscle in the right, will you work on the left eye?
Well,
and how?
Yeah, I mean, if you have let's say, the things to do in the other eye is very similar what you do in a paralytic problem. So if you couldn't find the muscle, and if you make a transposition, but despite transposition, you have a limitation of duction, and then you have a diplopia problem, and then of course you can go on to the other eye. So it's because it's a balance that you need to rebalance the alignment and the motility. Of course, you can go to the other eye if necessary. Yeah. And especially, let's say, in one of the patients in the post-traumatic child, if you remember, after surgery for the inferior rectus transection and inferior rectus palsy, and he obtained some limitation of elevation. So if there will be significant secondary overaction in the sound eye, that I'm going to disinsert this inferior oblique muscle as well. Of course, you may need to go on the sound eye.
Thank you.
Right. Thank you. And we have a question from Professor Dr. Samir Al-Mulqi. Dr. Samir, can you go unmute yourself and go ahead with the question, please?
Hello. Thank you, Dr. Seyhan, for such a nice presentation. Actually, this kind of topic is rarely tackled in such a profound and experienced way. So thank you very much. I want to commend you about that. And thank you, Raed, for making all this possible. Your efforts are very clear. So thank you again. My question is, have you ever considered using the EMG probe to localize a slipped muscle? I mean, just at least to know where is it.
Thank you. Well, I don't think it's a good idea. I was doing EMGs a lot in previous years, and I'm still doing it while injecting toxin. So, but in a slipped muscle, so what I'm going to obtain by making an EMG is this muscle has an innervation, and that's it. Because the EMG examination only gives you the information where the tip of your needle is. So where the tip of your needle is, if it goes to an innervated muscle fiber, you will have a good signal. So it will not give you the location of the muscle and so on. And in a slipped muscle, the concern is not the innervation. In a slipped muscle, the concern is the location of the insertion. So if you wish to make an examination to see the insertion site, I mean, you may try to do the anterior segment OCT, or you may try to do the UBM. But if you're considering a lost muscle, and you may go on with MRI, of course. But I don't think EMG is a good idea in that case, because it will not give you the information that you need.
Okay, thank you.
Right.
Thank you.
Thank you, Dr. Samir. Thank you, Dr. Seyhan. We have a comment about this topic from Dr. Muhammad Yunus from Lebanon. Dr. Muhammad Yunus, do you want to comment on the EMG and the built-in OCT in the microscope? Dr. Muhammad Yunus, can you hear us? So Dr. Muhammad Yunus' comment was about if you have a microscope with a built-in OCT, sometimes you can localize the muscle fibers, and also he is, agree on localizing the muscle fiber using the EMG probe also.
Well, this is maybe the previous question was considering while you were searching for the muscle using this EMG signal, one of the EMG machines, simple EMG machines, had such an option. I thought that he was asking putting the needle into the muscle. Well, in that case, the EMG is, well, I don't use topical anesthesia, and I think operating a lost muscle case in topical anesthesia is not my routine, actually. I don't think it's a very good idea, because as in the case demonstrations that I've demonstrated to you, you may have to go very, very posteriorly. So it may be helpful, but for this instrument's opportunity to use the EMG signal during this, I haven't used this. I don't have this type of instrument. But sometimes it could be helpful, but I don't have this type of experience. I think I'm just guessing. Is it possible to join the previous colleague who asked the question about the EMG. Can we join with him again?
Dr. Samir?
Yeah, sure. I'm here.
So were you asking about the EMG needle tests that you do as on an office setting before the operation, or were you asking to use EMG during the surge in the operation?
No, I actually was asking about the needle that we use before the surgery.
Okay.
The same,
so
the same way.
Then I answered your question correctly. Thank you.
Yeah, okay.
All right, we have a question from Dr. Layan Zaytoun. Do you want to unmute yourself and ask the question, Dr. Layan?
Assalamu alaikum, Dr. Raid. Thank you, Dr. Özkan, for very interested talk and discussion. I have just one comment. You show us on your slides one case who presented with large XT. And on exploration, you found that this patient has stretch muscle and also slip combined, I mean stretch and slip. So you did for him, you excise the stretch scar and you reattach the muscle. And at the same sitting, you did for him lateral or for her lateral rectus recession. Post-op, she had ET and you have to give Botox. So I'm wondering why not, because I used to do what? Only I did this, excise the stretch scar and reattach the muscle. I don't touch the lateral rectus from the first session. Most of them, or the majority, more than 95%, they did perfect and they have full adduction, and they are ortho. So just I'm inquiring why you did lateral rectus recession at the same time, please.
Thank you. Well, this is a very good question. Well, the reason why I did a lateral rectus recession is first, this was a very long-standing deviation, including some orbital components. This is the first reason. And the other reason is I'm doing adjustable suture surgery. So and when you do an adjustable suture surgery, you don't need to concern to wait and to see and so on. And after the adjustment, she was quite good. But then this contracture, so the level of contractures in that kind of muscles may go to both sides, and it's sometimes you don't see what you expect to see, but this was my point. And she had a very large deviation, and this was a long-standing one, and I was doing an adjustable suture surgery.
So you advise to do this in long-standing cases only?
Of course. Well, well, if this would be a very fresh case, I mean, if I would see this patient a couple if day after surgery, of course, that would be it would be okay just to advance the muscle and see it. But this was a very long-standing one. It's been nearly 20 years something.
Thank you. Thanks a lot.
Thank you.
Thank you. We have a comment from Dr. Shada, I believe our colleague from Saudi Arabia, about the extraocular muscle aplasia. Dr. Shada, will you unmute yourself and ask or comment? Dr. Shada, are you with us?
Yes, I'm with you. I was answering Dr. Salim's question.
Go ahead.
He was asking about if there's any way that he aligned the eye with the muscles that he described to be very thin. And I just heard about the titanium T-plate, and I just wanted to bring it to his attention. I've never tried it and I've never seen it, but I just wanted to answer his question and try to help him. That's it.
Okay.
Thank you so much. I'll try to find it.
Okay. We have a question from Dr. Walid, I believe.
Hello.
Dr. Walid, تفضل.
Hello. Hi.
Yes.
Thanks a lot for the nice talk.
Can you raise your
just a question about your experience, Dr. Seyhan, about repeated slipped muscle. So in the first you attached it back and everything went well with you, and then you have it again and again. What's your plan for those cases?
Well, actually, I have never faced a slipped muscle to recur again and again. And if it is happening again and again, it seems that there is something that is done in a wrong way again and again. Because the thing is, when and then you need to reconsider the ways of suturing, because sometimes if the tenons is behind your sutures and so on, you may face this type of problem. But I mean, if you secure the muscle in a good way, then you don't expect the slipped muscle to recur in this way. I haven't faced with such a problem. It may recur, but when you have great care in putting your sutures and I normally suture them more than I do. I mean, I put one more additional suture and so on. But if there is such a problem, I mean, you may consider it in a, let's say, in a like a thyroid patient and so on. You may have lots of restriction and so on. But I've never faced with such a kind of problem for repeating the problem for many times.
But you will not do sort of a recession of the lateral rectus if it happens with the small angle or something like that?
Pardon?
You will not do small recession.
The question, raise your voice.
You will not go for small recessions of the antagonist if you don't want to operate again for small angles?
Yeah. For this, well, now I see what you wanted to ask. For this, so for those operations that recently became popular in recent years, for very small operations, for very small deviations, I always prefer to inject botulinum toxin instead of doing surgery in those very small deviations. It is much easier and gives you a good result without cutting tissues.
And it will maintain?
Yes. I mean, the point is you need to do early. If you are late, you may the deviation may recur. But in small deviations, the rate for having a permanent effect is, even in chronic ones, is higher, because, you know, there's a tendency for the toxin effect. Let's say when you have a deviation, let's say you have a patient who has regular toxin injections. For some reason, the patient doesn't want to have an operation or already have lots of operations and so on. The tendency is the amount of the deviation in time has a tendency to decrease in time, and the period between injections tend to increase in time. And for those small angle deviations, they usually do quite well. I didn't have any patient for these small angles who regularly have to inject, have to receive toxin injections for lifetime and so on. They usually resolve in time with 1 or 2 injections. Those very small deviations that I'm talking. Yeah.
Thanks a lot.
Thank you. I have one question for you, Dr. Seyhan, about the anterior segment ischemia. Actually, in my practice, I never seen a single case of anterior segment ischemia. How many cases per 100 you have seen, or per 1,000?
Well, in my ophthalmology career, I haven't seen any serious anterior segment ischemia case. I have seen, but I must say that I have seen a 17-year-old, totally healthy girl, just after a simple recess resect, pupillary abnormalities. So these may develop even in young ages, but you need to identify those problems. You need to look with the slit lamp to see the tiny signs of anterior segment ischemia. Well, I didn't face it with a severe anterior segment ischemia, but it mustn't mean that we don't have such a risk, because we take great care not to face with this awful problem, because if it occurs, it is something awful. I mean, you may lose the eye, you know. So we have to be very cautious for not to face with such a problem. So the reason why we don't face with this problem is that I think it's because everybody takes care of it.
Okay, thank you. I think Dr. Muhammad Yunus from Lebanon is with us. Dr. Muhammad, can you unmute yourself and share with us your comments about the OCT, about the EMG? And while you prepare yourself to speak, maybe you can answer if you have seen anterior segment ischemia in your career of ophthalmology. Dr. Yunus, can you hear us?
Hi.
Hi.
Can you hear me?
Yes, we hear you.
Good
clearly.
evening, everybody.
Good
Hello.
evening.
I missed
Finally.
you all. How
Finally.
are you?
Thank
Actually,
you.
it was
Thank you.
excellent. Thank you, Seyhan, as usual.
Thank you.
Usual. And regards to everybody, especially you, Raed. Thank you for arranging this, actually. So
Thank
just
you.
for the information, just the issue of the transducer of the probe or the probe itself. When you are in the operating room and you are just in having problems, just get the probe and see if there is any firing of the muscle or fibers, muscle fibers, and just you can hear it. If not so, you can use what you said. You just do MRI later on, and then you go ahead and do another surgery. And for the issue of anterior segment ischemia, I've only seen once during my fellowship, only one case. Yeah. John Lee. It was missed from refer. And so this is.
We can't hear you, Dr. Yunus. We can't hear you now. Your connection is lost.
Connection, actually, bad connection.
Yeah.
I don't stop. Hello?
Yes, we hear you now.
Yeah, actually bad connection, and we have generators in here, and the Wi-Fi goes on and off. So this is why. So this is what I want to comment, and thank you very much for this nice presentation, and nice to just see you all during the lockdown and everywhere globally.
Thank you.
Thank you. Bye-bye.
So I think we have came to an end. It was really a very interesting discussion and lecture. Thank you, Professor Seyhan Özkan from Turkey. Next time, hopefully, we can arrange another lecture, another topic, and we can see you again.
So thank you so much. It was my great pleasure. And thank you for your moderation. And of course, the hidden hero of this web conference is Mr. Tevfik. I don't know
Thank
if
you,
everyone
Dr. Seyhan.
can see him. Thank you so much. So he had been able to teach me with those teams, even to me.
You are more than welcome.
Good.
More than welcome. And thank you to Novartis company, Jordan. They have been a great help in our preparation of lectures in Jordan during this part of the lockdown.
And also, I would like to mention that I do hope to meet in a real meeting, in a real physical meeting, and I do hope to see you all in the next ESA-ISA meeting in the magnificent atmosphere of Paris without the fear of COVID-19.
Yeah, inshallah.
Inshallah, yes.
Okay, very good. Thank you, Dr. Seyhan, for this actually very nice presentation, fruitful one. And thank you, Dr. Raed, for this moderation. Yes, do you have anything to comment?
Just one thing, Dr. Seyhan,
Yes.
this lecture has been recorded.
Yes.
Once it is ready, we're going to send you the recording so you can upload it to YouTube or wherever you want.
Okay, thank you.
Thank you, everybody.
Thank you.
And
thank you. So, and I would like to thank all attendees, and we hope to see you soon. Thank you very much, and bye-bye.
Thank you. It was